Great. Good afternoon. Thanks everyone for joining us at this month's Maternal and Child Health Research Seminar Series talk entitled Artificial Intelligence in Medicine and Imaging, Examples from Maternal and Child Health. We have a very distinguished set of panelists, which will and presenters today, and which we'll get to in a moment. Next slide. I want to thank the Education Committee shown here for the suggestions and putting together both the committee and the monthly seminars, as well as our annual symposium. If you want to join the committee or you have any suggestions, please send them to the committee's way. They're very open. And next slide. Also just wanted to highlight, for example, our fifth annual MCHRI Institute Symposium this fall. Please put Thursday, October 20th on your calendar. This is going to be an amazing symposium focused on community engaged research, which is one of the big goals of MCHRI in the next couple of years. We actually have this amazing distinguished panelists, Nina Wallerstein, Nikela Cook, Alicio Perez-Stable, and Alonso Plau, from different aspects of community engaged research to basically teach us about how to implement such these programs here at Stanford and in our local community. So please join us for that on Thursday, October 20th. And there'll be a call for abstracts as well for the symposium. Next slide. And then wanted to highlight this Thursday's 22q11 deletion syndrome symposium, where there's a spotlight on immunology. So please join us for that this Thursday at 8 a.m. And look on the website for the Zoom link. And then the next slide. Upcoming symposia, May 2nd, since May is Mother's Day, we highlight the maternal part of maternal and child health, and it will be a focus on in vitro models for pharyngeal endodermal cell development from Vittorio Sebastiano's lab. And then in June, a really new faculty member, Anna Gloin, will talk about diabetes genetics. So please don't miss those upcoming monthly symposium. But today, we're very fortunate to have this panel of Kurt Lungletz, who's the professor of radiology and biomedical informatics, and really the director of the AMY program, which uses artificial intelligence with clinical imaging to promote efficient and effective health. And so he's also the director of the Stanford Healthcare Medical Informatics Systems, which basically takes images that are produced and then uses them for clinical use. And so he'll start off and give an overview, and then two focused vignettes, one from Heidi Dalrymple-Link, and also professor of radiology, and another from Alison Callahan, a PhD in Nigam Shah's lab. And so we're really in for a treat. Please, as always, there'll be a link afterwards for suggestions about today's seminar, as well as questions and answers at the end. So please put them in the Q&A or in the chat. And with that, I'll hand it over to Dr. Lungletz for today's presentation.
Tony, thank you very much. It's a pleasure to be here with you all today. I am an adult chest radiologist, and I have my own AI research lab, but I'm here really today to talk to you about what's going on in AI in medicine and imaging and the AMY Center, and to give you some ideas as to how the AMY Center can support your work if you're interested in working in this area. And then at the end, we'll feature two investigators, as Tony said, doing maternal and child health work in the AI area. So I want to start because this is something that's not as familiar, some of the terminology to everyone. What is AI? Methods that enable computers to do tasks that normally require human intelligence. And that's a commonly known term. The disadvantages of that term are that, number one, it changes over time. So TurboTax, if any of you use that, the rules in there, the smarts in there used to be what we called AI when I studied AI back when I was a graduate student, or planning a route on a map used to be AI. Now that's just routine and on our phones, and the AI is actually driving the cars. The other disadvantage is that it has sort of a tendency for anthropomorphizing the abilities. So just because something can an AI can drive a car doesn't mean it can read a chest x-ray, doesn't mean it can play chess or Jeopardy or anything else. We have to train these algorithms for narrow tasks. Machine learning is a specific kind of AI. That's the kind that's just exploded over the last several years. And that really is about feeding data into algorithms, and the algorithms modify themselves and improve based on exposure to positive and negative examples. So the simplest case of that is the regression that you learned when you were in statistics class. You feed data on height and weight of children, and you get an equation back that helps you predict height from weight, specifically two coefficients, parameters that help you make those predictions. And these new methods, neural network methods, are very similar. They're still just math. It's just a lot more complex math, having to do with backpropagation and gradient descent, and the methods that the computer scientists have figured out to make the models improve slowly. These very complex models with sometimes millions or billions of parameters. And then deep learning is something you hear quite a bit. The deep just refers to the depth of the neural networks. And you can see there on the left, there are many different architectures for these neural networks. But almost all of them that we commonly use now have many layers. And so we would consider them deep. So deep learning has become kind of a synonym for neural networks. How did we get here? How did we get excited about all of this? It really started with something called Imagenet, which is a database put together by Fei Li, who's a computer science professor here. 14 million images of common natural scenes, typically featuring a single object in the middle. You can see on the left there, the garden spider. And it's reasonably complex task. So you have different backgrounds, different orientations of the object. And this database contains more than 20,000 different labels, hundreds of birds, trees, musical instruments, etc. And so each year, a competition was held by the computer scientists to see who could do the best at identifying, build an algorithm that could identify these objects. The kind of old style AI was being used in 2010, 2011. You see the error rates there for this competition, over 25%. 2012 was the first year someone succeeded using these new neural network methods. This was Jeff Hinton's lab at the University of Toronto, and you can see the error rate dropped dramatically. The next year, almost everyone was using the new neural network methods, and Jan LeCun at NYU won it. Then a team from Google won it, and the error rate kept dropping. Microsoft won it. Teams from China and Singapore won it. And the error rate started to flatten out. At that point, one of Fei Li's postdocs thought, I wonder what the human error rate would be for this reasonably complex task. So he set about learning about all of these dogs and cats and birds and musical instruments. His error rate was about 5%. So you can see we're getting near human level performance, and the performance was stabilizing in this image interpretation task. And so that's when they decided they needed a more complex task, which was this automated captioning. So now we have multiple objects in the image. All of these captions, again, this is out of Fei-Fei's lab, were generated automatically: bottle of water, cup of coffee, plate of fruit. And of course, when medical imagers saw this, we thought, that's what we do, right? We look at images, we find objects or abnormalities, we describe them. So the application to healthcare was quite obvious. And so it really began in the imaging world, although now it's really broadened to many other different worlds. Specifically, what do we mean? We're feeding positive and negative examples to these neural networks. And I like this schematic because it's got the Greek letters. It's really emphasizing this is just a series of mathematical equations that we're fine-tuning based on whether the algorithm gets the answer correct or incorrect. These backpropagation, gradient descent tell us how to modify these parameters and make the algorithm a little bit better each time, so that over millions or billions of iterations, it gets to excellent expert level performance. This is just an example of one of these. So each colored box here represents tens of thousands of parameters. So all told, this model is millions of parameters. And if you look inside, what is this network really doing? The early layers here are doing things like edge detection. That's why sometimes these are called CNNs, or convolutional neural networks, and then detecting structures and substructures and ultimately full objects. So that's what these algorithms do. That's what got everyone excited about it. And that's when we decided to found the AMI Center for AI in Medicine and Imaging, with an initial focus on images, but has since expanded to multimodal sources of data, as you'll see. We conduct and support interdisciplinary machine learning research that optimizes how clinical data of all forms are used to promote health. And that sort of interdisciplinary flavor is in our DNA. We're focusing on near to midterm clinical application. And the theory is that applied and foundational research aren't necessarily opposites, that really, if you're working on difficult and interesting applied problems that are clinically important, you're likely to encounter the need to develop new and interesting methods. And that's proven true for us. We now have over 140 affiliated faculty across 20 departments, predominantly in the schools of medicine and engineering, all here at Stanford. You can see some of the luminary computer scientists we collaborate with there on the bottom right. And our really first job, the thing that we focus on, is high quality team science, and everything else really follows from that. So we've published in places like Nature and JAMA and other places like that, and try to build algorithms that have an impact on patients. Just to emphasize this, the fact that imaging is kind of in the lead here, but by no means is exclusively the scope of these new methods. This just represents all of the AI machine learning enabled software as medical devices that were cleared by the FDA. And you can see the rapid growth here in the late 2010s. And if you look at the distribution of those, about 70% currently are in radiology, and about 85% of them are imaging if you total it up. But the rest of the medical world is catching up, and there's a lot of interesting work being done outside of imaging as well. Just to give you a flavor, I have a few examples of the early work that we've done. So this was the first model that we built out of our lab, led primarily by David Larson. This is bone age. So we take an X-ray of the patient's hand to get a sense of their physiologic age based on the development of the wrist and hand bones. It's based on an atlas called Grulich and Pyle, which incidentally happens to be the highest grossing book in the history of Stanford University Press. But we thought this was ripe for this kind of application of neural networks, built it and published it in our radiology journal. I believe one of the first publications in that journal on these kinds of methods. Here you can see the, the kinds of heat maps that can be generated to show where the algorithm is paying attention, and we were comfortable with that. We then went on to a clinical trial, a multi-institutional randomized controlled trial of this algorithm that showed that, in fact, across 5 centers, that radiologists augmented. So here the x-axis is difference from the ground truth, mean absolute difference. So you want to be to the left here, and you can see that the orange dots, which are the augmented radiologists, were better generally at each center than the non-augmented radiologists. So showed that, and this is going to be a theme, rather than competing with the radiologist, it's really radiologist plus AI, or physician plus AI, caregiver plus AI versus caregiver without. Some other work done by Matt Lundgren, who many of you probably know, on 14 different abnormalities on chest X-ray. This was in adults. And you can see equivalent performance on 10, a little bit better on 1, a little bit worse on 3, but near human level performance on interpreting chest X-rays with these 14 abnormalities. Here you see nodule and consolidation, and you can see the purple dots here are performance of the algorithm relative to the green, which are residents and board certified radiologists. Again, expert level performance across the board. Another example, this is a coming trend, opportunistic screening. So on the left, we have what's called a gated CT. So we're imaging the heart, imaging the chest at the same point in the cardiac cycle, which freezes the heart. And that gives us the opportunity to measure the calcium in the coronary arteries, which you can see here. And that is a measure of cardiovascular risk. We do about 1 million of those in this country every year. They cost a couple $1,000s each. On the right, we have a routine CT, which we do 19 million of them in the country every year. And we don't gate the heart. So you can see the calcium is somewhat smudged, but these are done for nodules, pneumonia, trauma, a whole variety of reasons. but we built an algorithm that could assess the cardiovascular risk based on the smudged calcium that we see here. So we get a way of screening for coronary artery disease and finding many patients who probably should be on a statin who don't know it, for no additional cost. So that's opportunistic screening and some other opportunities there in osteoporosis and other disorders. And then finally, these kinds of methods are being incorporated into the devices themselves. So this is work of Greg Zaharchuk's lab. And you can see here an MR in this first column. And then we have a low dose. So this is 1% of the PET dose. And using these two images, creating a synthetic image that predicts what the full dose PET would look like. And then here's the actual full dose PET. You can see there's a nice correspondence there. And this publication showed that it really did not affect the diagnostic accuracy of clinicians interpreting these images. So a very nice way to reduce radiation dose, reduce contrast dose, reduce time in the magnet, potentially reducing the need for anesthesia, for example. So a lot of that kind of work going on to produce high quality images from lower quality images. So that's just an overview of the area of this area with a particular focus on imaging. I want now to just describe some of the ways in which the AMY Center itself supports researchers here at Stanford. And we have these 4 pillars, and I'll go through each of them briefly. So first we'll talk about catalyzing extramural funding, which we like to do. So we have a series of grant programs, seed grant programs. In 2019, we gave out 7 $75,000 one-year grants. These were predominantly focused on imaging at the time. That was our focus. But you can see diversity across cardiac dermatology, radiology, some more foundational, some more applied. So a wide variety of these projects. We've since gone back and did an accounting of these, and 5 of these investigators have already gone on to our grants, and the ROI to the organization is about 15-1. So a highly successful program. Then on the basis of that, we more recently in 2021 had matching funds from the university-wide AI center called the HI, or the Human Centered AI Institute, and provided these 6 $200,000 2-year grants. And you can see now, again, diverse projects, but not just imaging, really across the board, and often multimodal data, including imaging, EHR, other forms of data like genomics. And then lastly, something that you could take advantage of right away is that we do have a Google Cloud credit program. So if you're doing intensive computing, machine learning, and need computing credit in the cloud, you can apply and receive up to $20,000 of research of cloud computing credits and storage credits. Interdisciplinary collaboration. So we do a lot to try to bridge the gap between the computer scientists and clinician scientists. One of the ways we do that is something that we've called boot camp. It's really a project-based learning activity. It's something, it's been on hiatus the last couple of quarters, but we will be starting it up again soon. This is particularly has been a collaboration with Andrew Ng, who you see in the middle there, a computer science professor. So we advertise for students. The students get course credit. About 20 of them are selected. And on the first day of class, clinicians and clinician scientists come with their nice data sets and their interesting clinical problems. And the students break up into teams over 1 or 2 quarters and solve these as part of a team. We also collaborate, as I said, with the Human Centered AI Institute, which is really looking across industries at the effects of AI. So workforce, ethics, cross-cutting issues like that across industries like national security, education, business, and of course, health and others. So we collaborate with them on the research grants, as I mentioned. You may have heard about our AI and health meeting we held last late fall. We have an AI executive education committee course coming up soon with HI. And then we have a health policy committee where we try to find the work that's going on at Stanford and elsewhere that's AI relevant, and that we really would want policymakers like congressional staff to know more about, that can really inform them as they make policy relative to AI. We also are building data science research infrastructure, and this is the on-the-ground work is predominantly done by Somali Dada's team at the School of Medicine, but we have helped to some extent, and I won't go through this in great detail, but essentially what we're doing is we have helped to migrate data. So for example, all of the last 10 years of data from our PACS, both pediatric and adult population, is now migrated over to the STAR data repository and linked up with the electronic health record data. So you can request not only EHR data, but you can also request the images associated with those patients. We have some tools to select cohorts of images, in addition to selecting cohorts from STAR, from the other data, ICD, CPT, and other codes, methods to label images, and then some platforms where algorithms can be deployed for clinical trials. And then educating and engaging. So this may be interesting if you have a particular interest in learning more about this area. So you can sign up using the QR code or the link at the bottom here, just to be on our mailing list and learn about the seminar series. We have an annual symposium that attracts about 2,000 virtual streamers, the AI and Health meeting, which is a CME meeting with tuition. And then our weekly seminars, essentially Research in Progress Journal Club. We have panel discussions and so on. So if you're interested in that, please feel free. The other way in which we engage with the world is we think it's very important to work closely with industry. Stanford has programs called industry affiliate programs. There are about 75 of these programs around the university. Ours is the only active program in the School of Medicine. And it essentially creates relationships with these companies and a particular part of the school, in this case, the Amy Center, where we have common interests. We want to have frequent conversations. Perhaps we will be engaged in planning a larger project. So some of these initial affiliate relationships grow into strategic affiliate relationships, which are larger resources involved around a specific project of mutual interest. And that's where we do matchmaking between these industry, these companies, and particular faculty and laboratories who may be doing work in an area. So again, we like to offer that for those companies where intellectual property is not an issue and there's not a need for deliverables at the end. They could become an affiliate. It's very quick. It's a matter of a few weeks to get this up and running, as opposed to contract negotiations, which can sometimes take much longer time to put into place. So again, we have about 15 affiliates now. This is a growing program that's really led by our executive director, Joanna Kim. The other way in which we engage with the world is through our open data program. So we have released now 15 imaging data sets, which I believe is still more than the rest of the world combined. And we are working on the ability to release non-imaging data. Non-imaging data is a little harder because it's a little more complicated to de-identify that data, but we are working with the Privacy Office and others just to find the right procedures to make sure that the privacy has been respected and the data is truly de-identified. We have a multiple step process. One step is electronic, the other step is a human process. And we have a more recent partnership with Microsoft because these data sets can get quite large and they were really overwhelming our infrastructure, which was just on box. The Microsoft infrastructure allows for quick downloads for one, and also tracking of who is downloading the data, making sure the license agreement gets signed, and giving a way to search various categories of data sets as the number of data sets grows. So that's been a really successful kind of a program. So that I hope will give you some idea of some of the activity going on here at Stanford and how the Amy Center can support people who do work in this area. So as you're looking at our beautiful new space here at 1701 Page Mill Road in Stanford Research Park, I want to now introduce two individuals who will provide examples of the type of work we do in more detail and that Amy Center supports. They're both, as I said, maternal and child health examples, one in imaging and one in other structured data and text from the EHR. So I'll introduce now Dr. Heike Daldrup-Link, who's professor of radiology and pediatrics, specializes in pediatric oncology and molecular imaging, to tell you about her work, which was funded by one of our most recent Amy High grants. So Heike, I'll stop sharing and please take it away.
Yeah, thank you, Kurt, so much for the introduction. And I also want to thank Kurt and the AMI program and the HAI program for kindly supporting our work and for also connecting us with collaborators from IBM, which has been extremely fruitful for our project. So let me just go on full screen here. With my project, I want to give you an overview of our work on standardized therapy response assessments of pediatric cancers. And again, this was an interdisciplinary effort of the Stanford AMI program, the HAI program, and also collaborators from IBM. So I want to start with the problem that we are trying to solve, and that is therapy response assessment of children with cancer based on 18 FDG PET-MR images. And we started by looking at patients with lymphoma. And as many of you might know, overall in the United States, there are more than 90,000 such patients, both adult and pediatrics. And these patients have to undergo at least 3 PET scans, one at baseline, one during an interim scan after some initial therapy, and then one at the end of therapy. And so these patients get at least 270,000 scans per year. And this is probably a conservative estimate because many patients actually get more than 3 scans. So on the left-hand side, you see an example of such a scan. And this is a patient with Hodgkin's lymphoma who was injected with radioactive glucose. And you can see a mediastinal mass here, which took up the radio tracer, and which is very well seen on the PET scan and then also on the integrated PET-MR scan. And at baseline, and we scale the metabolic activity of this tumor based on a 5-point scale, which is a purely visible, based on the visual impression that a nuclear medicine physician or radiologist might have. And this score goes from 1 to 5. 1 is no uptake at all, and 5 is an uptake that is markedly higher than liver or mediastinal blood pool as the internal standard. So as you can see here, this patient at baseline had a score of 5, a radiotracer uptake markedly higher than liver and mediastinal blood pool. And this here is a follow-up scan after initial chemotherapy, and you can see that the tumor completely resolved. And so in this case, this would be a score of 1 after chemotherapy. There's no uptake left at this point. It has been shown that the results of these PET scans can predict the outcome of our patients. Here's one such study that showed that if the interim scan is negative, then these patients have an excellent 2-year progression-free survival of more than 90%. But if the PET scan after initial chemotherapy is positive, that means there's residual radiotracer uptake in the tumor, then the overall survival can be quite poor. So also over the years, this scoring system that we use has been further refined to define exactly which tumor sites we have to measure and how we have to measure them in different anatomical contexts. So here you see how sometimes the result can be a little more ambiguous. Here you see a PET-CT scan of another patient with lymphoma, and you see the initial FDG uptake, which was equivalent to a score of 5. And then here you see the interim scan, and you see there's some intermediate uptake of a residual lesion. And this was scored as 3. It was more than liver, but still, it was more than the mediastinal blood pool, but less than liver as an internal standard. So hematologists have evaluated more than 600 PET-CT scans, And they found that actually this intermediate scoring of a score of 3 is quite common, and in their data set applied to 50% of the cases. So in these cases, it wasn't quite clear if the scan was clearly positive or negative. In addition, they found that there was quite a high inter-individual variation of these scoring systems, especially around when the score is around 2, 3, or 4. So we wanted to tackle this problem with a computer algorithm and tackle number 1, the problem of a more reproducible automatic score. And number 2, perhaps in the long run, introduce additional criteria that might allow us to make these intermediate scores more specific by considering more variables that we get during our clinical workup. So we started with PET and MRI scans. These are introduced into a convolutional neural network. And the first task for this network is to label regions of the aorta, liver, and different tumor sites. From there, then a subsequent algorithm will measure the radiotracer uptake in labeled tumor regions, and from there generate the Deauville score. So we had to even divide this task further into a subtask for different body parts, because that turned out to be easier for our computer system to learn. So we start with a whole body PET-MR scan based on 2D image slices. We apply an encoder that determines if these different image slices come from a specific body part. And then we apply the different algorithm for the different body parts in order to label mediastinal blood pool, liver, and the tumors. So currently we are actually testing several algorithms, and here are just 2 of them. In the process, we came across one challenge, and that is false positive lesions. As you can see here, here's our previous patient with the mediastinal mass. And you can see this patient also has some lymph nodes in the abdomen, and then the urinary bladder shows up as false positive. Our patients get simultaneously acquired diffusion-weighted scans. And on the diffusion-weighted scan, you can see that the tumor is also positive. And here we also have some other false positive lesions, for example, the gallbladder and the gonads. You might notice that the false positives are different on the diffusion-weighted scan and the PET scan. So we are now considering both these data sets together and are trying to identify the tumors that are positive on both on the PET scan and on the diffusion scan in order to improve the specificity of our approach. This is just one solution to this problem of potential false positives. So here you see our preliminary results. So far, we applied a small training data sets of 25 pediatric patients with lymphoma and serial imaging studies and their lesions, which we annotated. We also have a control data sets of 12 patients that do not have any lesions in order to teach our system what the normal anatomy is. And here on the left-hand side, you see again our patient whom I showed you earlier, after manual segmentation of the tumor lesions. And then here the automatic detection of the tumor lesions. We can actually apply a different threshold for the intensity of FDG uptakes that we measure. And so here we focused on the areas that take up a lot of radio tracer, because that's what we usually measure on our imaging studies. So we usually measure the SUV max, the maximum radio tracer uptake. So as next steps, we need to increase our training data sets in order to help reduce errors and false positives. We need to more optimally fuse PET and MRIs. This is particularly important for children who sometimes move. And so the 2 data sets might not align automatically. We have to help with that. then ultimately we want to integrate information about tumor size and blood biomarkers such as LDH in order to potentially make this automatic score even more specific than currently available through human interpretation. And ultimately, we want to correlate human reader-derived Deauville scores with the AI-derived score. I also want to take just a minute to introduce another project that we are working on also through this collaboration with IBM that I mentioned earlier. And that is on reconstruction of ultra-low dose imaging data, which should improve the safety of our imaging scans for children. Here, we also use PET MRI images, and we actually use ultra-low dose PET images that we consider together with the MRI images. The MRI images provide the anatomical information for our ultimate scan, and the PET data are only used in order to determine the radiotracer uptake and the degree of metabolic activity of a certain tissue. So with this, we could actually augment ultra-low dose PET scan with about 6% of the radiotracer dose. And so you can see here is our result of the AI reconstructed FDG PET scan, and we could achieve nearly a identical image quality compared to the standard dose PET scan. And we also made sure that SUV measurements would be consistent on these two scans. So Dr. Langlotz mentioned many different applications of AI, and I showed you image reconstruction, computer-aided detection, and disease classification. And we want to work on these other applications also in the future. Ultimately, we think that together we have to ultimately answer one fundamental question, and that is, do these new technologies improve the quality of life and life expectancy of our patients? By how much, for how many, and for whom? And again, I'm hopeful that we can work together to answer this important question. With that, again, I want to thank the AMY program for kindly supporting our project, and I want to thank our team for their contributions of this work. Thank you so much.
Well, thank you, Heike. That was tremendous. And I think we can all see the value in particular of using some of these algorithms to standardize the interpretation of these studies. We all know about the problems of inter-observer variability and the ability to run an algorithm and know that it'll provide the same answer on the same image really has an incredible value. At this point, I'd like to introduce Dr. Allison Callahan, who's a research scientist in biomedical informatics research in the Department of Medicine. She collaborates frequently with Nigam Shah in his lab, and she's going to talk about her work extracting information from the electronic health record. So Allison, take it away.
Thanks, Kurt. All right, I'm going to share my screen. Hopefully you will see this. Let's see, we just did this. Okay, we will not share a portion of my screen. Try one more time. Okay, here we go. All right, now you should hopefully see my slides.
Yes, we can.
Perfect. I'm going to, these were 2 hard acts to follow. I'm going to try to take the last 8 minutes to talk about a project I've been working on for about the past 1.5 years. The project is called Progress. That's the name of the database. It's an obstetric database that I've constructed using electronic health records data and text mining methodologies, and that's the AI portion of this work. So the main motivation of this work is that when we want to learn more about the patient factors or the individual factors that contribute to different outcomes in pregnancy and birth, a lot of the available data sets that we have access to are really insufficient for this task. On the one hand, we have data sets like the Women's Healthy Initiative survey, which followed a large number of women over a fairly long period of time, but was limited in the variables that they collected specific to pregnancy and birth. We also have really high quality survey data from NHANES, for example, but they also rely on self-report data. And when you winnow it down to patients who have experienced a pregnancy or birth, the sample sizes can be quite small. On the other hand, we have really large claims databases from insurance companies like Optum and MarketScan that have tens of millions of lives represented in those data, but are also missing key information like parity and prior pregnancies that are really key to studying pregnancy and birth. So in my lab, a lot of the work we do revolves around extracting useful information from electronic health records like what we see at Stanford. This poses its own set of unique technical challenges when we're talking about reproductive health, pregnancy, and postnatal outcomes, some of which are record linkage between parents and child. If a person seeks fertility treatment here at Stanford, all of those records are linked, but that's not a guarantee for every person who has a child here at Stanford. A lot of the information that is relevant is in unstructured data, and this is where AI methods can really shine in extracting valuable information from unstructured content like clinical text and notes, and that's what I'll talk about more specifically in a couple of slides. And then there's the problem that plagues all EHR-based studies, which is the potential for missing data or bias in the information that was collected in patient records. But we do what we can. The basic workflow of the project that I undertook was to build on the foundation of STAR OMOP, which is a version of Stanford's electronic health records data that has been transformed into a standard representation or common data model in the middle here that collects information or captures information about patient diagnoses and treatments they've received, procedures they've had performed. This is probably familiar to some of you. This is available to everyone in the School of Medicine. It's another, Kurt talked about it as well, led by Somali Data, an excellent resource. And we built on top of that a series of obstetric data extractors to construct additional rows or columns in this table that is information about different patients seen at Stanford. So that includes things like parity, prior pregnancies, gestational age, and so on. So what does that actually look like? For each patient in Stanford, we looked at their patient timeline. If they had a record of a birth here at Stanford from diagnosis codes, then they were entered into our database. We took a window of time 5 days before and after that event for each person and extracted the progress notes and labor and delivery notes from their record. This is the full text content of those notes. And then we also added an additional window 280 days back in time and pulled flow sheets, which are more structured form elements in EPIC that contain information on plurality. So that's number of babies, a twin or not, presentation, so vertex or breech, and then also gravidity and parity. So that's prior pregnancies and births, and gestational age. And we developed extractors that took the form of regular expressions and queries to structured elements in flow sheets. That was sort of our starting point. My hypothesis was that we would be able to glean a lot of useful information with these relatively simple methods, specifically related to these 5 variables of interest. And so to test that hypothesis, and this is where I get to call out my wonderful colleagues in maternal and fetal medicine here at Stanford, we actually took a set of patient records randomly selected from 2017 and 2019, and Gaia Marukapan manually annotated those records to identify the gravidity, parity, gestational age, plurality, again, that's number of babies, and presentation for each of those records. And we were able to use those manual annotations to evaluate the performance of our obstetric data extractors. As you can see, my hypothesis was correct with a lot of these variables. We actually did quite well, but there is some room for improvement for parity and gestational age, and then also recall in terms of extracting presentation. So that being said, we were pretty happy with these initial results, and we went on and used our database to identify a low-risk birth cohort that is useful for epidemiological studies. So that is patients who have not had a previous child, whose baby was born at term with the vertex head first presentation and was a single baby and not a twin. And so we identified about 9,000 such patients who had what is commonly called an NTSV birth as our initial project using this data. This is just a bar chart showing the number of births that we have a record for from 2016 to 2021, which was the period that we focused on in our initial study. And we presented this at the Society for Maternal and Fetal Medicine annual meeting this past February. What's next is two sort of focused efforts. The first, and this is again where AI comes back into the picture, we want to improve the performance of our data extractors using weak supervision. So this is a methodology that I have a lot of experience working with in other application areas that essentially aims to take advantage of a set of simple labeling functions or rules that can be applied to label a set of data in a very fast and scalable way that can then be used to train neural networks. And the advantage comes with the scale at which we are able to generate labeled data for learning these models that's given to us by using weak supervision. And so this graph on the right here, this chart, shows that when you take weak supervision approaches and use them to generate large labeled training data, we really improve performance. The blue and the orange lines here are the performance gains that we get compared to the purple here, which is hand labeled. And so this is really a powerful methodology that we will apply in this space to improve the content of the Progress database. And then this is where I also get really excited. What we want to do is use the knowledge in Progress database to fill gaps in what we currently know, because we have this sort of narrow window around the birth event for each person, but we also have all of their other electronic health record data going far back in time. And we can use that information to learn about drug usage and its association with pregnancy and birth outcomes, to improve comorbidity scoring systems, which we know don't perform well when applied in the maternal or obstetric setting, and also to improve predictive models that typically aren't applied or even incorporate data from patients who have a pregnancy or birth. So that's a really big gap, and that's what I aim to try to fill using Progress DB. I'm at time. Thank you so much. If this sounds interesting to you, I would love to talk to you about it more. Thank you.
Allison, thank you so much. It really highlights many things, but in particular, the value of not just large amounts of data, but large amounts of well-labeled data. And clearly you showed some of the methods that we use for that. At this point, we'd like to take your questions, and I see we already have some, so please do use the Q&A link or the chat to provide questions to us, and they're already rolling in. So the first question is, what are the advantages to partnering with industry? What do they provide that Stanford can't? So that's a great question. A few things. One is industry often has expertise that we don't. So they may have expertise on bringing products to market. They may know more about what customers are looking for in new products. They have sometimes really excellent engineering expertise that we don't have. And if we're building these kinds of algorithms, we really would like them to ultimately reach patients. And we can certainly put them in a clinical trial here at Stanford, but to get them there to reach beyond Stanford, that's where it's really helpful to have an industry partner to do that kind of dissemination effort. And then also, I think worth saying that industry comes with resources, so they can help us support some of the work that we want to do here at Stanford. Another question, are images from the PDC, which I think is Perinatal Diagnostic Center, ultrasounds, also migratable to STAR? I don't know the answer to that question. If it's in the PACS, the answer is yes. If it's, I know we're about to bring on a new system called iMorgan to deal with our ultrasounds. And so I believe that if they're not, they would soon be, and that's something that we can certainly take back and look into to see whether those are part of the database. Let's see, here's a question in the chat. Does it make sense to generate synthetic data sets based on our data for machine learning? Maybe Allison, I'll direct that to you. What software was used for labeling? Yeah, so what did you use for your weak labeling efforts? And what about this issue of synthetic data and these other technologies that can be useful for machine learning and protect privacy?
Thanks. Yeah. So to the question about what software was used for labeling. So not sure if this refers to the data that we used for evaluation, but if that was the question, Gaia was able to use Epic Workbench to actually look at patient records, and she had access to all of the information about those people that she would normally use in making her judgment about patients. So that's how we labeled the data for evaluation. The software we used in prior work that leverages weak supervision methods, we used Snorkel. And this was a collaboration with Jason Fries, who got funding through HAI last year, and Chris Ray, who also was in Kurt's slides as well. So that's the software implementation of weak supervision that we use. And there's a more recent implementation of a more advanced method by Jason called Trove that's used for entity classification. That is what we will use for future work in progress specifically. As far as generating synthetic data goes, I think that can be useful for evaluating sort of expected performance of certain methodologies. I think I tend to like the approach of weak supervision, which still leverages human expertise, but in a more scalable way to label data, which in the sense is, you could think of it as sort of a version of a synthetic data set, but it's more of a programmatically labeled training data set that will still have some noise in it because the labeling functions aren't perfect. But that tends to be outweighed by this fact that we can generate really large training data sets that are what you need to get great performance out of neural networks. So,
yeah, and the synthetic data falls into a category of technologies that includes differential privacy and federated learning, which are ways in which you can perform machine learning experiments on disparate data without compromising privacy. But there's and very promising and interesting and worth investigating, probably not quite ready for replacing the kind of work that we do with real data. For example, there's some early work to show that synthetic data does a pretty good job of answering some basic questions about frequencies, particularly with events that occur frequently in the database. But as you start to get to rare conditions or underrepresented groups, it's not going to be as accurate in corresponding to the original data. So more work to be done there, but an interesting set of research questions. Let's see, Heike, question for you about baseline data and ground truth depending on what clinicians have previously input. Mm-hmm. And how do we reconcile that with socioeconomic issues and diversity? And how does the ground truth and our kind of sometimes very weak ground truth, which is people's opinions, how do we avoid just taking opinions and incorporating them into these algorithms when maybe they're biased?
Yeah, I think this is a very important point. And actually with our engineers, we had long discussions about this. So number one, so our problem is quite complex. So number one is detection of tumors at baseline scans. And typically in the pediatric oncology world, almost all of our tumors are very hypermetabolic. And so there the task is relatively straightforward. And here, yet we still have some inter-observer variability when different people generate the Deauville score. So there we are actually taking multiple human readers and compare that to our AI score and see how well they correlate. And the step one is to just see, do we get a similar readout or do we get a different readout? Then ultimately, the Deauville score is generated for treatment monitoring. So we want to see how well the patients respond. For that, we need a follow-up scan. And now the task is much, much more difficult for the computer system because the tumor is not as metabolically active anymore. So there are like multiple facets that come into play, how we do that. But ultimately, we want to determine, does this patient respond to therapy? And that links to outcome. So ultimately, we take the outcome data. So we look at the progression-free survival of our patients and the long-term survival of our patients and correlate that with our readout and see which either human reader or algorithm correlates best with the ultimate outcome. And that will then also allow us to generate potentially a computer algorithm that could be better than the human reader. For example, by integrating blood biomarkers, which we already have for pediatric patients. So we already routinely look at LDH as a biomarker for our tumors. So, but radiologists don't integrate that information. And I think there's a huge opportunity to actually integrate that additional information and with that actually makes the score better than it currently is. The second was on the diversity of data. And I think here it's really important maybe to also work with data from different centers. Because inherently every medical center has a certain bias towards certain patient populations based on their location. And I think here again is a huge opportunity for these AI initiatives to generate pooled data sets and get data from different centers so that we can look at data from a variety of different patient populations. Mm-hmm.
Yeah, Heike, that's great thoughts on that question. And I would just add that as a general matter, when you're doing machine learning experiments, it's really best to think about that question of bias, not at the end when you notice that your data has bias and that you're trying to correct it maybe statistically, but at the very beginning. And think about even what questions are you going to ask with this algorithm to solve. You may be familiar with a famous example where an algorithm was used to predict who would be a high utilizer of healthcare services and make them eligible for some special support programs. But of course, people who had difficulty accessing healthcare services or were less likely to seek healthcare, even if they were equally sick, they had lower utilization, so became less eligible for this program. So you have to be careful not to bake in those problems into an algorithm and to fix the societal problem before you ask the algorithm. And then the other is, of course, just that you want to make sure that you have enough data from all the groups so that it can get an equivalently accurate answer for underrepresented groups and majority groups. So that's a matter of selecting the right data sets. So those are important questions. Another question from the Q&A, could we unify reports in the EMR, both radiology and clinical data, to use natural language processing to analyze that data? Yes, and in fact, so I'll take this just briefly and then maybe toss it out to Allison or Heike. So we frequently now build these algorithms and neural networks to process multiple types of data, even imaging and EHR data. We have a project ongoing related to predicting outcomes of pulmonary embolism that processes both of these data, and a lot of good foundational work to decide when is the best time to fuse the data. So you can imagine building two different networks to get two different answers and then adjudicating at the end versus kind of fusing it at the data at the very beginning of that neural network and have the network work it out itself. So a lot of interesting questions there. Allison or Heike, do you have anything to add?
Yeah, just that, I think we know this from our work with Priya and Somali, that in fact, you can already link radiology and EMR data in STAR by patient identifier. And so I have good news for you. And if you are a researcher at Stanford, then you can do that directly using the resources that exist. and that are maintained by research IT. So that has really been an amazing evolution over the last few years of this team that I think power a lot of the work and a lot of the funded work that now is supported by HAI over the past 2 years. So, yeah.
Good.
And then I
Well,
see there's a question about are there opportunities for high schoolers in our
Yeah.
lab? And the answer is yes. We often will take a person over the summer if the sort of alignment is there. So if that's you who's asking or you know someone, then you can send me an email and we can follow up.
great. Well, Tony, I see we're at the top of the hour, but thank you for having us today.
And thank you. I just again wanted to thank Dr. Langletz, Callahan, and Dr. Blink for really basically setting the bar high for how to use the system in our clinical operations. Please reach out to them for collaborations, questions, seed grants, or high school students if they want to work in the labs. Thank you very much. Really stimulating hour, and we hope to have more of this again in the near future. So thanks very much, everybody. Thanks for the questions. We'll talk to you next month for the Mother's Day version of our monthly seminar series. Take care.
Thank
Thank
you.
you.